Okay, so we dispatched to a 70-year-old male. Chief complaint is chest pain and a collapse. The history is acute onset of chest pain, unable to stand due to near syncope and dizziness. Previous medical history, he had an MI 5 years ago. However, today the chest pain feels a bit different. His presentation, he's pale, clammy, eyes open to voice, able to but unable to obey commands. We have no radial, but we do have a carotid. Bob, can you squeeze my hands for me? Can you squeeze my hands? He's not obeying any commands. However, he did say that his palpitations were going into his neck and his heart was going to jump out of his chest. He was sitting on the lazy boy recliner. However, now we've moved him onto the stretcher in a supine position. Sarah, do you mind getting a full set of obs for me and a 12 lead?
Will do.
GCS, we're going to go eyes to speech, so it's 3. Verbal orientated to time and place, 5. And motor, unable to obey commands, another 5. So we've got a GCS score of 13. How's those vitals?
We've got a BP of 70/40, rest rate of 18, BGL 7.6, and a temperature of 37.
Fantastic. So the patient has severe hypertension, and it looks like 170 beats per minute in ventricular tachycardia. He's unable to obey commands, so he is severely compromised and is a status 1. Sarah, do you mind calling for backup for me, please? R50 for VT.
Will do.
If patient was able to obey commands, then we will need to contact the clinical desk regarding IV administration of ketamine for sedation. However, we're still going to gain large bore IV access in the left ACF in case we need to administer any drugs if things go a bit pear-shaped. We've got bag valve mask set up on high flow oxygen if needed, and also an OPA. Just run through a few differential diagnoses. Patient is on Cilazapril, so he might be a bit dehydrated as well, therefore could have electrolyte abnormalities showing up on the ECG, which we treat with 0.9% saline. The rhythm may be SVT with aberrancy. However, we have broad complex tachycardia greater than 150 beats per minute. With capture beats and fusion beats, the patient looks compromised and has a history of cardiac issues. So we're going to treat as VT and Cardiovert. Sarah, do you mind running through the checklist with me?
Yep. Place pads in either apex sternum or posterior position in addition to ECG electrodes.
Apex sternum, done.
Ensure defibrillator is in manual mode.
Defib is in manual mode.
Select a lead with a visible R wave and ensure that the artifact is minimised.
Done.
Select synchronized mode.
Done.
Confirm there is a detection symbol above every QRS complex.
We have it.
Ensure patient has received adequate sedation if indicated.
Not indicated.
Select the joules, charge the defibrillator and confirm everyone is clear.
Selecting joules, charging,
Press and hold the shock button until the shock is delivered.
standing clear, shock delivered.
Determine the rhythm and the level of the cardiovascular compromise.
Okay, it looks like we might have sinus rhythm. Bob, can you squeeze my hand for me? Bob, can you open your eyes? Okay, he's squeezing my hand and opening his eyes.
If administering a second cardioversion, confirm the defibrillator is still in synchronized mode.
So we've gone through our checklist. Bob is now responsive. How do you feel now, Bob? Yeah, I feel like shit. Awesome.